Right, so we'll go on to debate number 6 now. It's performance of the health system. Our data from the industry, a real asset, with Alexandre Conroy, Patrick Erard, Françoise Grostet, Dominique Martin, and the debate will be led by Yves Juillet.
Well, good afternoon, everybody. We're going to talk about the industrial data and see whether they do contribute anything and what the terms are which would make them bring more. We have Françoise Grostet. Everybody knows her. She's a European deputy. And we also have Patrick Erard, Dominique Martin, and Alexandre Conroy. This is how we're going to proceed. First of all, we're going to try and understand on the basis of examples what the data from the industry is. Then we'll take a look at the expectations of the public authorities on this subject and have a look at the difficulties that occur within a framework which is obviously a regulatory one, but which is also political with the European specificities. And inside those European specificities, you've got the French specificities. We'll start with a few examples, and I'll hand over to Alexandre Conroy, who's going to tell us about his experience. Well, obviously, the data of the industry is very important. It's an asset that we have to use in the best possible way for the health system. I'll give you 2 examples, which come first of all from the United States. It's a surveillance program that we sell to the hospitals, 354 hospitals to be quite accurate in the US. And it consists of helping the hospitals to monitor nosocomial infections and a certain number of problems related to drug interactions. And obviously they use that in their clinical practice on an everyday basis. In the US, nosocomial infections contribute to the funding or no funding for the hospitals. But what's interesting is that we supply the data free of charge in some states to the insurance funds such as Blue Cross that insures the patients, and they use that data for their discussions with the hospitals. Another interesting thing in terms of public health is that we've signed an agreement at the White House with CDC to supply the surveillance data on multi-resistant organisms and on the use of antibiotics, which enables us to monitor the evolution. So do we have these things in Europe? No, for technical reasons to start with, but also due to the regulations. And we're making an effort today to try and host this data in compliance with the existing rules. And I'll give you a second example, if you don't mind, which consists in using connected technology to improve drug security. We're talking about the hospitals here. It's for identifying the patient and the library of medication, the speed at which it's administered with a pump. And these products are obviously rarer here today because of the state of the IT systems, whether you're connected or not. From what I heard yesterday concerning Kaiser and other systems, we're running rather late, unfortunately. So it's technical mainly. Yes, it's a delay that's due to lack of investment. We'll come back to those points later. Let me hand over to Dominique Martin. You've got a lot of data, Dominique Martin, because you ask for the data. But in practice, is there any data that you don't have and that you'd like to have? And what are the conditions in which you could retrieve that data? Yes, we have a lot of data because it's compulsory due to the European and national legislations. These data are handed on to us by the industrialists, whether they're the drug companies or the medical device companies. And we do have a large quantity of data. There's no particular difficulty there, but the main problem is a problem of quality. In the area of drugs, for example, the quality of the data is not always adequate. We need data that we can use to take decisions, and that is the main issue. The finality of the data is how can we use the data? There's a lot of data, as you know, but we have difficulties in terms of the accuracy and the volumes to process, and how we can set up automated systems to locate signals, and on the basis of those signals, how we can take decisions in the area of surveillance. That's where the difficulties occur, mainly related to the quality of the data. Before the new European regulations put even more constraints on the environment of the medical device industry, we have a problem of access to data. So that is a problem that you have. You've just talked about the difficulty of assessing the information, but is there any data you don't have and that you'd like to have, and if so, why? Or why would you need that data? Well, data that we don't sufficiently have is clearly in two main sectors. The first is on prevention of being out of stock. Sometimes we get the data too late, and it's important to prevent being out of stock as far upstream as possible so that we don't find ourselves in a situation where we have to replace the products at the last minute. That's crucial, and it's been occurring more frequently over the last few years. And in the area of surveillance, which is important in France, it's everything that concerns the misuse of drugs. That's a real difficulty, and we're discussing this issue with the industrialists at the present time. We have the information. We're beginning to have information on off-label use, but misuse is something else. It concerns general practice, how the products are used, not only off-label, but also the duration of the treatment and the doses and so on. And on these aspects, which concern the person who prescribes the drug and the user, we have a shortfall in information. In terms of quality, we haven't got accurate information. We lack action plans, which are the responsibility not only of the industrialists, but also of the public authorities. Paclic ERA, you've just heard two examples of data that could be useful to the public authorities. How does LEM fit into this? Well, before I answer that question, which is a very important one, let me say that the data of the industry is not just an asset. It's crucial for the ecosystem. We haven't waited for the debate to open to create the idea of sharing data. One of the oldest, over 30 years ago, we created GERCH to share economic data, and it's a reference now. So that's big data before the big data. And we participated in that. We participated extremely actively in pharmacovigilance. And this is not data that was created without the industrialists, but with the industry. And this data is shared. Today we have databases that we share with the authorities and is used as a reference by the authorities. Think of Oscar concerning the duration of the filing for visas and so on. And think of the data that was generated when we created the innovation database, which enables the community and the different agencies to plan for different innovations. So we're constantly creating the concept of this database, which is shared, so that we are responsible contributors to the ecosystem. To answer what Dominique has just said on being out of stock, yes, we're working on that too. We're working on that very hard indeed, because it's a complex issue. I'd like to recognize the work that was done by the Pharmacists Committee. They've done a considerable workload on the risk of being out of stock of drugs, and LEM also works on the capacity that we have to prevent these situations, which are sometimes also related to parallel exports. As you know, we've got to solve some of the legislative problems which have not yet been solved. And on the misuse of drugs, of course, we could also contribute even more and make sure that you have more visibility on how the drugs are used. But don't forget that in misuse you have the word use, and it's not the pharmacists that use the drugs. So we're probably going to have to get together with the health professionals, the pharmacists and the doctors, and see how we can take a long, hard look at this. It's not something for LEM, it's something more collective and far more complex. Just one point, and I hope we'll be able to debate that afterwards. Before we start wondering about what we could set up, we've got to start off by saying, well, what for? Very often we put the cart before the horses and we never answer the essential question, which is, what is the goal? I propose that we should move on, and then we'll take these points one by one. And I'll hand over to Françoise Grossetête. So we've talked about these difficulties, in particular what Alexandre Conroy said. There are some technical problems, but there are also regulatory issues to solve. On European level, what is the atmosphere like? Are we in a situation in which truly the evolutions that we've been talking about since this morning are taken into account? Or are we still seeing things in a very conservative way in the way we use the data? Well, I'd say that at the European Parliament, the people are really becoming aware of the fact that it's necessary to change the legislation, taking into account the changes in the practices used in health today. With digitization and connected health objects, all this means that the lawmakers absolutely have to approach these issues. When I see the title of the round table is the data of the industry essential? Of course it is. It's essential, absolutely essential. But that is going to lead us on to a certain number of questions, such as protecting private data, protecting the patient's data, and also, of course, protecting the commercial interests of the industry. If we want to continue encouraging medical research and innovation. So here we're trying to strike the right balance between protecting the patients on one hand, protecting private data, and protecting the commercial interests of the drug companies. And we've obviously got to have more clarity, more transparency. We need to hand over data, but we've got to protect research and innovation and the patient's rights at the same time. And you'll see that in some cases it's rather complicated. In point of fact, the lawmakers are looking into this. We're working on it now. We have a certain number of legal texts that are being written out concerning these issues. Thank you. You said a word, an interesting word, transparency. It's the first time we've heard that today, and I'd like to turn towards Patrick once again. He quoted the GERS, which is a good example, but are the industrialists prepared to share the GERS data? Because it seems to me that in the questions that Dominique Martin asked, there was mainly the question concerning misuse, and there are figures that are known to the public authorities, and there are also off-label uses that are not made available to the public authorities. The data that are supplied by this sort of panel, which is not actually a panel because the GERS data is exhaustive, that's one of the specific features of GERS. But the subject is not actually that. If you want to work on a shared goal that you share with the agencies and the industry, that concerns not just selling out, that's to say, dispensing the drugs behind the counter, but things that are far more upstream, such as which indication, what circumstances the drug was prescribed in, and is the patient going to run a risk with this, that, or the other type of indication. And that requires a different methodology. And it's probably not through this type of tool that we're going to be able to find the answer to that. Transparency, as it happens, well, that's all very well, but it requires a sort of exhaustive list, a nomenclature for prescribing the drug, and an adequation between the prescription and the patient's situation. And if I say that and scratch my head and think about it for a few seconds, well, we're not going to invent a new machine. All you've got to do is knock at the right door. People at the CNAM have all that data. When I say that, I feel a bit awkward because I think this is rather off subject, because we're talking about the data of the industrialists, and I was already in a reciprocal frame of mind. What Patrick is saying, in point of fact, is that nobody on their own can give all the data that we need. And he said it quite rightly too. He said which data for which need. We have a problem in France. Let's go back to misuse, which is not the only subject of the round table, but it is a true difficulty that we have, and it's something very specific to France. When we compare France with what goes on in other European countries, you'll see that we're in a situation in which there is more misuse in France than in other countries. The trend is quite strong, in fact. And if you assess the benefit-risk ratio in London and everything's fine, and then you import it into a country where there's a lot of misuse, you're not going to have any improvement to the benefit whatsoever, but you're going to, on the other hand, increase the risks and degrade your risk-benefit ratio. So what you need to know is how the drugs are used by the prescriber, but also by the user. And this is data that is very important indeed. And it's the industry's obligation to work on that as part of their obligations through all the reporting mechanisms. But they can't do it on their own. We need the information from the industry. We need to go into more detail in depth, and we're working with LEM on that, because we've got to take a closer look at misuse, because if we don't work on that, we're going to have a problem of iatrogenic effect. Earlier you said that in the area of medical devices, you had very little information. So can we ask Alexander Conroy to react to that? Well, medical devices are something very different. There's a very strict framework for drugs, but there isn't for medical devices. There's no visa to market them. The industry is very varied. There are big companies, small ones. There's less inspection, and people are querying the devices and the rating agencies, and there are millions of medical devices that circulate in the country, more than 11,000 specialties, which means that it's a very, very complex sector, and some parts of the sector are dangerous. Not glasses, of course, they're quite safe, but there are, and glasses are medical devices. So we lack information for the reasons I've said, because it's a very complex sector, and for an agency such as ours, it's difficult to get all the information. In the coming years, we're going to be able to reinforce what we do considerably by going halfway towards what happens in the drug sectors with the periodical reports and more inspection by the rating agencies and so on. And we're expecting a lot of the new regulations so that we can control the environment better, because it's very complex. And there are a lot of new devices. They have a very short half-life. in the industry, things rotate very fast. And when you've got an implanted device in your heart, you've got it for the rest of your life. So it's very, very specific, and the difficulties have to be dealt with. Good. Alexandre Conroy, have a comment. Well, I won't contradict Dominique Martin on the very great variety of different medical devices available. It's perhaps an asset, but it's very complex for the lawmakers. And Françoise Grostet is certainly going to have to do something on the European level. I think that for the safety of the health system, I'm not defending the whole of the industry, I'm speaking for myself, but I think we probably need better regulations in medical devices as in general. And I think that serious people have nothing to lose in this whatsoever. It would avoid perhaps imports that come into the country and then get of doubtful quality and then get the CE mark stamp put on them. So that's for the regulations. But if we come back to the subject, which is related to data, there's a very specific prospect there, because we've got to take a look at how we define a medical device. Between the connected watches that I saw some of the speakers with and other types of medical devices, there's quite a lot of work to do to define them. We've got to see when an object that supplies diagnostic data becomes a medical device, or is considered as a medical device. It depends on, does it depend whether it's measuring your blood sugar levels? Well, that could influence your behavior. And I think there's a lot of work to do on this level, and you've got to be very careful. I like the distinction that was made between the precautionary principle and the principle of prudence. And I'd like to draw your attention to something else in connected objects, and that's cybersecurity. It's a subject that hasn't yet come to Europe, but I think it's going to do so very soon. It's a major concern in the US, in the hospitals, because the security of the information systems is important. And if the data is accessible, then we're going to have problems of cybersecurity. And I'll probably come back to our viewpoint on that subject. Yes, we'll see about that later. Now, Françoise Grostet, how do you find your way around this difficult world of medical devices with several million of them, and how can you manage this sort of situation on the basis of the fact that the files for the Mark CE have nothing to do with drug files, and they mustn't, because otherwise it will be the death of the medical device industry. So how can we retrieve the data from the industry that's useful for the public authorities? Well, for medical devices, but there are other examples as well, such as clinical trials, for example. I think it's very important concerning this problem of data. If they don't have a visa, and we had long discussions in the European Parliament for that purpose, some wanted there to be a visa. We were told that the visa for medical devices was truly something which was going to slow down innovation. We rank them, of course. There's a classification. We draw a distinction between implantable invasive devices, for which we have to make sure that they're perfectly safe for the patient, and those that are a lot less dangerous, such as glasses or crutches or dressings or things like that. We're totally aware of that. And it is true that transmitting data is essential in these cases. But what we're asking for is to make sure that these devices can be tracked. And we disagree on one point. We haven't solved the problem yet, which is of great concern to me, I must admit. There's a lot of pressure from the Germans to accept the recycling of these devices. And we know why, because there's a very big company in Germany that and it's in their interests that the medical devices should be recycled and that this should be authorized. It's a battle that we're fighting, and we want to impose a system to track these devices, including the responsibility of everybody in the chain of events concerning medical devices, so that we can find the information we need as quickly as possible and get all the data concerning any given device. And we're discussing these issues right now. We haven't finally solved the problem yet, but I fear that the pressure from Germany is going to be too much for us. We're not going to be strong enough. I don't want to hide anything from you. It's difficult. We're fighting. It's a question of majority, and sometimes it's just a question of 2 or 3 votes. So we're going to try and persuade the largest number possible. Right. Well, you've mentioned the issue of clinical trials, and maybe we should take a look at that. Let's hand over to Patrick Erard for that. Patrick, there have been a lot of discussions on that subject. The industry's worked on it, and they've taken position. In January 2014, we were at FPA, and a certain number of measures were taken to move forward on this subject, in particular on the capacity that we have to make commitments on the communication of the results of clinical studies as soon as they've been reported, and communicating the results to the patients when they were enrolled in studies, and publishing positive results, of course, and negative results. And that was acknowledged in the collective commitments that were made and signed. And there again, there's a goal, the goal being transparency. And there's a goal to propose a foundation that will set out what the right use and the inappropriate use is. Little by little, the situation is probably going to be turned around. You were worried about misuse, but with customized medicine and the development of monoclonal antibodies with antibodies with markers, the question of use is going to become obsolete, because you'll have a mapping system that is going to define the right use, which is the added value of customized medicine. And this is where it really is a major breakthrough. It's going to change the paradigm of surveillance and all the data concerning these drugs, which is why there's a certain value in them for life, of course. And I think we're going to have to be capable of taking a look at the transparency of the use and shift towards the paradigm of new medicine. What we're proposing, not for the future, but from now onwards, we have monoclonal antibodies and products that are really major innovations that are really going to totally change the prognosis of fatal diseases today. And that's something we have to put into the way we process our data. And we're going to have to ask the industry to set up surveillance systems which may be obsolete in 2 or 3 years' time. Right. Thank you, Dominique Martin. A comment, Patrick Erard? That's partly true. I do agree with Patrick, but things are probably going to develop fast, but there will be a coexistence between modern and customized medicine, which is not a problem as far as I'm concerned. So the two will have to coexist, the new and the older therapies. As far as we're concerned, it's not the upstream problem of the information from clinical studies and new drugs that are of concern to us, we're equipped to detect the signals. But when you've got 11,000 specialties, some of which are very old and are not going to disappear from the market, we've got to be able to detect signals on commonly used older drugs as well. And that's the problem for us. It's the problem of information that we need from the industry. As I was saying to Patrick, you mustn't abandon. We must have that information and targeted information, including on the older drugs. I'd just like to remind you that the major problems that we've had over the last few years are mainly on older drugs than on the new ones, the more recent drugs. Alexandre Conroy would like to react, and then I'll ask Patrick Erard a question. I don't think you should reduce the debate to the aspect of just drugs. You started off by saying there was a lot of data, but unfortunately you didn't know how to use it. And I'll come back to a theme which I think is a very important one. On one hand, you've got to protect the data, got to make sure the data is protected, and there's something very exciting that we talked about this morning that concerns everything that the data from the industry can contribute. And one of those things is that it can help the health system to put their information in order, in the right order. Companies that work in the area of software, for example, can help. If we just have a little vision, we can defragment the silos of existing information. There have been a lot of breakthroughs in technology that should enable us today in 5 to 10 years to solve the problems of silos of information which we have today. And that would give us information that is useful for the hospitals, for the health authorities. And that's the exciting part, but some of it is of great concern as well. What about the situation with the older drugs, which is very difficult, especially for products that are now generics? The Princeps laboratory usually has the information and says, oh, that's not our problem. They don't supply it. How can you manage that? Well, by asking the right questions to start with, and wondering why, after so many years, you've discovered all of a sudden that the product has been used for other indications, or for indications that weren't necessarily on the label 5 or 15 or 20 years earlier. Perhaps by asking yourself those questions, you can prevent things going awry. And there's obviously a common denominator that can be used. Perhaps you could stop reimbursing a class of drugs and use another. That has happened recently. I won't quote any names. And we'll see mechanically what happens if you move the use of a product which is no longer reimbursed for economic reasons to other classes of drugs. Then you may see an effect that you didn't see before. So is that the right weapon to manage this problem of the right use or misuse of products? Well, probably not. But the other question is that you need to have a shared goal with the NSM about what you want to monitor, because you can't monitor anything. It's like any other battle fighting against iatrogenic effects, for example. And you've got to accept the fact that life is not 100% safe everywhere. But I think there are some things that incur more risks than others. So we've got to agree on what we need to monitor and focus our energy on shared goals rather than doing things the wrong way around. Setting up a system, thinking wrongly that it's going to detect everything, because I don't believe in that. Well, let's change the subject a little and come back to the protection of data. First of all, I'll hand over to Alexandre Conroy, because the problem of data that he has is aggregated data. How do you process the data? And what interfaces would you like to have to consider that you're doing your job properly? And then we'll ask First of all, Dominique Martin, how he sees that issue, and then Françoise Grossetête, because she could probably do the wrap-up on that subject. Well, I don't pretend that I'm an ace in technology, but the data that we collect from the hospitals are data that are anonymous and depersonalized. That's not a total guarantee, of course, which is why I come back to the distinction between prudence and precautionary principle. There are guidelines issued by the FDA. To be quite clear, there was a major incident in the USA where the infusion pumps were hacked into, and after that the FDA set up guidelines on the accountability of the manufacturers of medical devices for the safety, the security of their software. It's not a regulation, it's just guidelines, but even so, it does establish a certain number of rules, and you've got to take care, because protection of data is like protecting your own belongings. It's not total. As soon as there's a leak somewhere, somebody must have done something wrong. We don't want hackers hacking into everything today, obviously. The important thing is to develop means and to put all the means possible into the system to prevent these things happening, encrypting the data, for example. I think that's the responsibility of the industry, making sure that the data is anonymous and that it's not handed on any old way. That's my position as an industrialist concerning these obligations, which are legitimate. But of course, you've also got to host the data on national level, and there you need to pay attention to the fact that through the regulations you don't change Europe of connected objects up to Europe of GMOs, because there's a difference between data protection and innovation. Well, we're not very competent on the issue of protecting personal data, except that we've had to process very big databases, Asteram, for example, which is one of the major databases in France. And the whole point is you've got to find the right balance between the protection of personal data and we're fortunate enough in France to have CNIL, which is a very good organization for that purpose, and we have some very good legal advisors too. In our practice as regulators, we don't have a problem having access to data, but we're not at ANSM, we're not in the world that we've just described. That's to say, that very new world in which things are becoming more and more complicated. It's more that the development of connected objects are going to be a problem in the future. And we've got the individual freedom also to consider. As a citizen, I don't like being monitored by anything at all, but somebody who's chronic disease may accept it. Having something that monitors your blood sugar levels or other things is something I would find unbearable myself. Françoise, how can we strike the right balance? Well, we've got a legislation that is underway on the protection of private data, that you quoted earlier. We're currently negotiating with the Parliament, the Council and the European Commission. The subject is particularly sensitive at the European Parliament because as lawmakers we need to protect the citizens to start with, because you've just described the risks that the citizens may have to bear. So we don't want a legislation that goes too far or that is completely negative in its impact and that will create a lot of red tape or be truly something that's going to slow down innovation? Well, that's loop the loop to a certain extent, yes. In the protection of private data, the regulation has a very broad field of application because it also concerns medical research, which is why I'm talking about it. And it is planned that data can only be transmitted with the patient's consent. And there's a very tricky debate underway because the European Commission made a proposal that was fairly satisfactory. And then the Parliament, it's the European Parliament that decided to become a lot more rigid. And I don't agree with that. The European Parliament took position and said that the patient's consent had to be given every time the data concerning that patient was used. Well, the system would obviously be extremely difficult to use. It's a disaster. And that's one of the harder problems to solve when we are discussing these issues with the Parliament. If there's a high degree of public interest in it, I think that we shouldn't have to ask for the patient's consent, and I would be in favor of just one, asking the patient once, and once the patient has said yes, it's done, and you don't go back on that. The Council is thinking about a system of consent that you wouldn't have to ask for again if there is a high degree of public interest in using that information. But the problem is it going to pass or not? Well, the problem is not simple, and Europe doesn't seem to be in a better position than in the US. We've got 3 minutes left. I'd just like to ask you, in 30 seconds each, if you had 2 wishes to make to improve the situation, what would you propose? Dominique Martin, 30 seconds. I think that we must integrate into everything we do the patient. I think that that's essential. It's not just a generous vision, it's utilitarian because the patient is essential in the chain of information. Yes, I think that's very basic, and on the European level that would be useful too. Yes, of course. I wish that we should move forward because we're concerned by all the developments in the area of health and all the e-health, big data and so on. These are all essential issues, and we've got to be able to do everything we can to go as fast as possible. I was very sorry about the healthcare across borders, and I wanted something on e-health there, but the member states wanted to slow down, and we had to find a trick to write things out on by not imposing everything but suggesting e-health. But we've got to work in synergy, not only with the industrialists, but with all the member states, because even if France is ahead of the others in many areas, there are 28 member states, and they don't all go at the same pace, and that's something you've got to take into account. So going fast, but going well, because it's in the citizens' interests. Alexander Conroy. I'd like to come back to something rather technical but important. If we want to obtain all the benefit we can from the existing data and make sure that it's protected, it's in our interest to think about this in terms of the whole healthcare system, way beyond the medical records. In the medium term and the long term, we've got to make sure that we can ensure the interoperability of the systems and have interfaces between the hospitals so that we can really draw benefit from the system. And I think we're far from doing that. And we need that in France to reap the benefits of our technology and that vision. And the second thing is that I hope that Françoise Grosset is going to be able to maintain her position at the European Parliament. Patrick Erard will put all the health players around the table to create the objectives for these shared databases. Assemble people, not divide. The problem is that we always have rifts between us, and we've got to invent a database which is efficient for the healthcare system. That's a dream. Perhaps we'll be able to stop counting our pennies in the healthcare system at last. Thank you very much for participating.